All right, well, thanks everyone for joining us today. Today we will be finalizing our fourth session, Community of Practice on Prevention and Practice, Behavioral Health amongst Individuals with Disabilities. In today's session, we will be focusing on improving behavioral health engagement for individuals with severe chronic disease. So just as a kind reminder to everyone, that all participants are muted upon entry. Please make sure you also engage in the chat, and we highly encourage you to also participate verbally during today's session as we go over our different case studies. Please also feel free to just go ahead and unmute your line if you're able to, and whenever you would like to participate. This meeting is also being recorded. The slides and recording link will be sent to you via email. And again, please provide just a brief introduction about yourself in the chat. And thanks everyone. So today, again, in case you guys don't know me, my name is Filipina Sandoval, and I'm a TTA manager here at NCHPH. And with me, I have my colleague, our director of research, Dr. Kevin Lombardi, who will be leading today's presentation. All right, so without further ado, I will pass it on to Dr. Kevin Lombardi to get us started with a quick review.
Hey guys, veterans care is really important. Unique patient population, and they're everywhere, all over the country. Puerto Rico, Alaska, you go any municipality, you're gonna find veterans there. It's a good population to understand, and it's a population where disability and behavioral health access are core issues. Now, veterans have in general good access to the VA compared to those who are not veterans. The barriers tend to be different. Just because you have access doesn't mean you are aware of that access. And it's incredible how many people who are eligible for VA benefits don't actually use them to their fullest. Navigation is important for this population, but also not just the resources, but the diagnoses themselves. In my experience, veterans uh, 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 can be resistant to the idea of a behavioral health diagnosis. Now, of course, everyone's different, but that's been my experience in general practice. I navigate that with how I discuss and how I describe the symptoms. So, I want to go briefly over the case where we went over last time, briefly, just to nail or hit home some points. Then we're going to continue the case study where we left off, and then we're going to start talk more about chronic disease and disability, because in many of our patients, the source of their disability is a severe chronic disease. And those types of disabilities both evolve differently and must be treated differently. Next slide, please. So let's refresh our memory about Mr. Jones and sort of the significance of his past medical history. He's here for a wellness exam. Past medical history, he has chronic disease in type 2 diabetes and hypertension. He also has a very significant behavioral health history, major depressive disorder, post-traumatic stress disorder, and generalized anxiety disorder. We don't know about suicidal ideation. There's nothing in the record, and we haven't asked him about it yet. He's also a regular tobacco user, but has been in remission for 1 year. He is disabled at 50% service disability. He's a Desert Storm Navy veteran, and he has severe back pain, lumbar degenerative disc disease, and associated lumbosacral radiculopathy, also referred to as sciatica, very debilitating conditions, in particular when a patient has excess visceral fat, excess weight, and when the patient, excuse me, and when the patient's pain is not addressed appropriately. So, anyway, next slide. What we find when we look at Mr. Jones' history is that all of his chronic diseases and his behavioral health issues are being upset by existing social issues that are happening in his life. So he has lost his job. He is living off his veterans benefits that don't pay all of his bills, and he is becoming very stressed. We can see that in his vitals here. His blood pressure is higher than when we last saw him. Heart rate's higher. And from the results we get, we see his A1C has gone from 7.0 all the way up to 8.4. This is a patient who's across the spectrum. Their chronic diseases are getting more significant and more difficult to treat. The source of that, as we discussed last time, is really the stress and destabilization of the patient's financial, social, and occupational lives. So, next slide, please. And through the questionnaire, we kind of went through this, but the patient is experiencing multiple structural issues related to the loss of his employment. Next slide. Thank you. And next slide. So he sees a provider that's a also a veteran, and we notice a couple of different things that shows that his chronic diseases are getting to the point in severity where they are potentially leading to independent sources of disability and inability to complete the functions of daily living. In particular, that 1.1 plus pitting edema on the feet. Does anyone remember why, when you see pitting edema, as in when you push the patient's foot, your finger makes a little indent that takes a second to kind of get back? That pitting edema, does anyone remember the condition that gets us really concerned about? It's abbreviated with the letters CHF. You remember, Fide?
Congestive heart
Yeah,
failure.
yeah, that's it. It's because it's a congestion, right?
Mhm.
The blood backs off, and that 1 plus fitting edema is a classic symptom that's not diagnostic of, but highly suggestive of that condition. Now, there's two types of heart failure: right side or left side and right side. Left side is when the heart can no longer push against the blood pressure, and it can't put the can't put the blood effectively into the bloodstream, and it backs up. And then there's right-sided heart failure where the blood from the body is congesting as it's going into the right side of the heart. Left-sided, we tend to see things like that pitting edema. Right-sided, we tend to see water in the lungs or fluid in the lungs, but it varies from patient to patient, and there's a little overlap. In general, that's how we make a distinction here. So this patient is significant or concerning for left-sided failure. We'd of course want to do a lung exam at this point for this patient as well to hear if we have any fluid backing up into his lungs. Next slide, please. He's also, as you do that, we're also concerned about depression and anxiety and SASI, because the patient is noting verbally that there's some things that are concerning, that he's describing his depression in an indirect way, that he's very tired a lot, that he's very frustrated and stressed out. When you hear those three words together, ask yourself, is there any reason this patient would be maybe trying to tell me about depression without going ahead and saying they're depressed or using the classic symptomatology? Veterans tend to do that, especially this generation of veterans. Next slide, please. So he is screened. He is significant for depression and anxiety. Both are fairly severe too, and the patient is recommended for behavioral health treatment. He then reveals a number of things that are sort of leading to the cascade of stress to chronic disease. And you'll see this with patients quite a bit. And over the years, you sort of, as you bring together more cases and you're exposed to more people, more stories, more narratives, you see it happen. But the patient experiences a stressor, their medical management breaks down because of that stressor, and that leads to a circumstance where chronic disease exacerbation is almost guaranteed. And that's what this patient is experiencing. But the loop doesn't stop there. It feeds back. So as the chronic disease gets more severe, it requires new medications, closer and more closer monitoring, and it becomes physiologically harder for the patient to complete those activities of daily living. Patients with severe disability, for example, excuse me, severe diabetes often complain of fatigue. That fatigue gets worse the worse that A1C gets, and that fatigue is a barrier to organizing one's life, to organizing one's medications, and so forth. So we really need to focus on those stressors when they are so clearly the first domino here. So for this patient, we assign them a community health worker to see them on a longitudinal basis. Next slide. Thank you. He's resistant. We convince him. Next slide. And now that we have him signed up with our community health worker, we can really start to see those stressors addressed. Now, he's being medically managed by his physician through the primary care center. He is being managed in a social sense through the CHW, and seeing a behavioral health provider now. That's the network. The interdisciplinary group that is working on this patient. The CHW will see him longitudinally over 6 months. This is sort of my recommended algorithm. Everyone does it a little different. The coaching style dynamic is what I recommend. It's what I think is best supported in the literature and what I think works the best for patients like Mr. Jones. Working with them gradually, over time, 2 times a month, a note submitted each time into the medical record, and focusing on goals, how to meet those goals, and following up on those goals. And those goals should be based on the express needs of the patient as seen in the non-medical needs questionnaire and as mentioned by them and assessed by the CHW. So that's a defined process. That's its own a whole other learning collaborative, but that's generally what I recommend for working with patients like Mr. Jones. Next slide, please. And this is where we took off, or we left off. So there's the review. And now we're going to look at his post-clinic medical history or medical narrative. Mr. Jones is contacted by a staff member who works for your facility via telemedicine. Excuse me. Mr. Jones is initially recruited to receive assistance and refuses a CHW assessment. He doesn't want to do the screener, doesn't want to talk to the CHW, changes his mind. The CHW bargains with him and offers him a couple of things. One, he can be consulted via telehealth. He doesn't need to come into the FQHC. And two, he can pick his own CHW. We can tell him who we have, and he can select who he wants to work with. He agrees. And those two things are good bargaining chips that are put in your back pocket. A lot of patients, in particular, our behavioral health patients, do not want to come in. They're more likely to not want to come into the office. Why? This is already scary. That makes it scarier. Have them do it from the comfort of their own home. They love it. And thanks to as a byproduct of the COVID-19 pandemic, most FQHCs have this material. As in by material, I mean the modules needed to, or the physical modules needed to perform the telehealth. There's not a clinical assessment associated with a CHW's work in most cases. So especially with Mr. Jones, we can do this on telehealth. We can have him come into the office on his next appointment for his blood pressure checks. As long as that is covered, that's totally fine. Do the telehealth and let him select his CHW. This guy said to us, listen, I don't want to do this because I felt judged in the past. He's going to be very selective with who he talks to. And if you find someone who has a similarity with her, and again, he's going to pick this himself, so he's going to find this. But it's great to have veterans on staff for this reason, because people like Mr. Jones are very, very very common. And they often, my experience, they enjoy working with other veterans. It's very similar to having someone just from the same culture or speaks the same language. It has a similar power to the patient. It's the same as if I had a patient who was from El Salvador, I would want to give them to the CHW who speaks English and Spanish, because they could speak to them in a culturally competent way. That is the case with veterans as well. For those of you who aren't veterans, you're still going to need to treat them. So, really understanding their narratives and their history and getting as much experience working with veterans as possible is something that will help you. You'll find over the years that there really are distinct generations of veterans, different theaters of war, different experience that shapes them in different ways. It's a fascinating addition to sort of the clinical milieu of your patient population, and something that I think you'll find a lot of interest in as you dig deeper into it and form bonds with these patients. So anyway, he says yes. So green light. He meets his CHW via the facility's telehealth mobile application on his phone. Boop. At the beginning of his appointment, Mr. Jones has a short introductory session with his CHW, who uses a number of interview techniques to make Mr. Jones more comfortable during his visit. Next slide, please. Question. If you were interviewing Mr. Jones, how would you encourage him to open up? You're sitting across from him. He's giving you the closed body language and giving you terse answers, short answers, not responding much, and is resistant to the idea of the therapy. And by therapy, I mean CHW visit, that is being recommended. How do you work with him? How do you negotiate with him? How do you converse with him? How do you address that? There's no right answer for this one, but there's a lot of right answers. Also, a lot of wrong answers. So, um, take a second, think, throw something into the chat, and then I will start podcasting on the topic. So, veteran hasn't been to the doctor in 6 years. Um, Chronic diseases are getting worse, very stressed out, closed body language, doesn't want to talk, very resistant to seeing the CHW, but in critical need of those services. Missing this patient could mean he ends up having severe decompensated CHW, congestive heart failure. This is a patient who could get worse to the point where the next time someone sees him, it's in the ER because he can't breathe because his lungs are filled up with fluid. That means you, Fide. We've got no fish biting, so you're the fish. How are you going to
Um,
get him up? You're a CHW. This guy doesn't want to talk to you. Doesn't want to talk to anyone, but especially you right now.
this is a bit complicated. Maybe, I mean, I'm here to learn as well because I don't have experience in this kind of work, but I would try to think,
It's human. It's very human. You talk to
yes,
people who don't want to talk to you all the time, don't you?
yes. But I think in this case, I would try to like kind of gauge and see where he's at currently, how he's feeling. Maybe like ask him, how are you feeling today? And maybe ask him what are some of like the challenges he's been having recently, and do it in a manner that I can like kind of have that trust building with him, not be so judgy or anything, and I just hear from him when he has to say.
That was a really good answer. I think that's the best one you've given at our sessions. You nailed it.
Thank you.
And the determinant was a single word that you said. And of course you talked about it. But there was a single word that you mentioned that was critical for this.
Mhm.
What's that word that you used? Can you
Trust.
think? Trust. Trust. This
Mhm.
patient hasn't been to the doctor in 6 years.
Yeah.
He has chronic diseases. Do you think trust maybe is part of it? He says people judged him in the past and he didn't want to come in. Yeah, that's a trust issue. You nailed it, girl. You found it. He needs to be listened to.
Mm-hmm.
Maybe he's only been talked to.
Yes.
A lot of veterans hate that, especially the ones that have been, in an armed conflict that is a
Mm-hmm.
big part of their identity. They feel like people should treat them with respect, and they're right to do that. And here's the secret: you should treat all your patients with respect, but we don't always do it because we're in a hurry. We're reading things quickly. That can come off without the intention of disrespecting a patient. It's very easy to do it. It's very easy to just be
Mm-hmm.
quick, just be terse. Like that's the thing that
Yeah.
over time turns people off. And
I
when
believe
you sorry, go ahead.
I was gonna say I believe Mary had her hand raised as well.
Oh,
Mary?
sorry, Mary. As I'm here pontificating, give everyone a break from my voice
No,
and tell
I
me what
didn't.
you think.
I didn't have my hand up. I was clapping at
Oh, okay.
something that Fide was saying and that you nailed. And then I noticed that Andrea said almost exactly the same thing. Uh,
Mm-hmm.
Let's talk about it then, because my understanding is that your background is in clinical nursing, and nurses are taught very differently than physicians. They're taught from the patient-centered model. So this is
yeah,
something
except that you never actually get to do it. You get in trouble if you do it because it takes too long.
exactly. But are you talking about me, the physician, or you, the nurse?
No, I'm talking about me as a nurse. Yeah, but
Oh,
but
well, we have the same problem.
I think we're yay. Yay, that means we're on the right track. But but I think we're all kind of like circling around the reality that chances are this person has just not been heard, not been met. Things are getting worse. They know things are getting worse and they're scared. And
Hmm.
they don't want to, they don't want to have to turn themselves over to a place that hasn't really served them before, but now they're just too scared. They know they need something. And what an honor for someone to dare to show up.
Mm-hmm.
Yeah, 100%. Imagine you mentioned the fear too, which I think sometimes we forget. Because we look at this stuff, I mean, when we're looking at these things, it's like nuts and bolts to us, right? We see it every day. Congestive heart failure, you're the third one person with this today I've talked to. It's not surprising or scaring me, right? To the person who didn't go to the doctor for 6 years and then comes in and they're potentially dealing with a new serious diagnosis, that's terrifying. Do you see people in the doctor's offices sometimes? They're shaking. You know why? Because they can get news that can destabilize their whole life. So it's scary. And that trust is a bridge to that communication. Oh, yes, that's fine. Thank you for sharing. Um, and uh, Andrea, you mentioned, okay, let me look at your comment here. Okay, so what's when you're asking him what he's facing, besides, just understanding it, what is that accomplishing for you with the patient?
Well, I would want to ask him how he's managing it just because just there's some assets. I'm sure there's some strengths. And so it's me just wanting to identify, what is he currently doing? And for me, it's just coming from a place of less judgment. I mean, I'm sure he's doing something right, even though he has some chronic conditions. So I would at least just want to start there, just to enter into kind of the more difficult discussion. Just try to start from a place that where he feels like he can assert himself and kind of share what he is doing correctly.
I like that approach. And the reason I like it is because the build from strengths approach. It is encouraging, right? If you look at it, if you take a different approach and you just look at what he's doing wrong, even if you're not saying it, if you're doing it in an indirect way by giving him the resources that are fixing what is wrong without acknowledging what he's doing right, that's a discouraging way to address it. Building from patient strength give you a couple of things. One, I think you just built trust by asking that, because he is sharing. something from his perspective of what he's doing. And you'll get challenges when he discusses that, and you'll get systems and some things that work. And two, it gives you an understanding of how the patient manages things and what's working. And from what is working, you can build on top of things. For example, the patient has severe pain. He's going about his life. He was working. Have you ever met someone with lumbar disc disease and sciatica? It is hard just to go to work. I've known patients that all they just going and doing a 6 hour shift totally uh, exhausts them for days afterwards because they have to physically and mentally deal with the pain that they go through. The fact that he was doing that for so long says that this was someone who was uh, doing something right. Right? He's got veteran benefits. He didn't need to work. He chose to. He could have done something else. So this is someone who had structure, and that structure my guess was debilitated by both the pain and the chronic diseases, and then that shock. That's a repairable system, and it's a system that he can repair if he's given the right supports. So when you ask him what is going right, with of course knowledge of the patient, you know what to build on. You know what things to give him first, what challenges he will thrive under versus those that will discourage him. We need to be very gentle with people at at these points in their lives because everything is vulnerable about them, how they feel. It pervades every part of their life. If you have a vulnerable medical situation, your social life will feel vulnerable because it hurts when you go outside. Your work life will feel vulnerable because it hurts when open the cash register. Your family life will feel like that because you can't go to parties because you can't sit down. You can't go on a plane or you can't take a ride. Uh, it's challenging. Building that confidence makes the patient feel like he can do more. And as they're learning to, say, manage their condition, they can do more. And I'll just give you the example of someone like him. For Mr. Jones, if we were able to support him medically, his diabetes, his chronic disease, his diabetes, his chronic pain, and his behavioral health issues. That's like pushing the gas into the pump when you're trying to turn the lawnmower on, right? It won't turn on. You push the pump. Whoa, whoa, there it goes, right? Because he's gonna feel better when those things are better. If you feel a little better, well, you might not be as depressed. Just off the cuff. Also, your depression is being treated now, and you're taking a full dose of your medications. Things feel better. Things feel calmer. Then you can start organizing things. You can start focusing on the things that are making you better. It's like tactile feedback. The patient feels better and does better, and you need to coach them through that because they don't know that that can happen. Everything's just been getting worse to them. And it's been very isolating. So when you make that connection with the patient, this initial connection, you set a foundation that you're going to build a house on top of, and that house is wellness, right? So very, very important stuff. And I will say that don't be scared yourself of patients like this. Reach out to them, show your own vulnerability when you can, and ask the questions and take that minute to listen. And again, I know we're running all over the place. We've got 15 minutes here, we got 10 minutes here, we got 5 minutes here, but a small gesture builds trust with the patient. It can be as small as something like direct eye contact and a smile, and I'm not kidding. Something small like that can make a difference with patients' systemic trust. But being able to have a conversation with them and listen, don't fill. My favorite word for this is bloviating. It means that you talk so much that you kind of fill the room with it. I have a tendency to do it at times. And I think we all can be a bloviator. Take that time where you could be talking and do a little listening, and it'll make your clinical practice better, and you'll do better, and the patient will feel better, and everyone's happier. Little improvements make everything better. Next slide, please. So now we're going to go through some processes of digesting this. And by digesting this, I mean getting this patient to talk and open up to the CHW. So this CHW is good, and they have a process. The CHW utilizes the following techniques to facilitate his interview. One, active listening. I love active listening. It's good. It's not just good with patients. It's good with friends. It's good with dating. It's good with your dog. Great with your kids. Do some active listening. I've got a 14-year-old. I just started doing, well, as I was doing this, I started doing some more active listening. It works. So active listening is across the board good advice. But for Mr. Jones, you need to fully comprehend his response. Take in when he's talking, look right at him, watch how his body is moving, watch how he is communicating. That tells you about the patient's emotional state, which often can say more than the words that are coming out of their mouth. It's amazing how much we communicate without saying a darn thing. How we move, how our body is positioned, tells sometimes more than what we're actually saying. And it's honest too. Tends to be more honest because it's very hard to control that for most people. Um, so this involves a complete concentration on the patient, no interruptions, unless absolutely necessary, and give them a second before you jump in. Patients don't like being stepped on. And I will say, I'm Italian American, and I grew up in a culture where people interrupt each other constantly at the dinner table. It's just our way of communicating culturally. Does not work with patients. If someone's talking and you sort of anticipate that their sentence is going to end and you begin talking already to sort of get in there and make efficient use of time, you're cutting them off. They feel it. Give it a second. Let them finish because there may be a little piece there that they didn't add. And that little piece can be very important. Um, so, adaptive questioning. Take your active listening and put in adaptive questioning. You listen to the patient, you ask general questions, and then you be more specific based on what he's saying. He's saying, okay, Mr. Jones, you're feeling frustrated and stressed. Wondering if you could tell me some more about those feelings. Well, I just lost my job. I'm on my benefits, and they're not paying all the bills, and my pain has been really bad. I haven't been able to fill my medication. Like I'm not even signed up for VA benefits. I don't know how to do it. Like I've always been able to manage this by myself. Like it's very frustrating. And then the general questions. What are you doing to manage it now? What's changed based on 6 months ago? And he'll say, "Oh, well, I lost my job, and like I've been getting headaches. I've been feeling really fatigued, and I just found out my diabetes is a lot worse. I'm really worried about that because my grandfather had his legs cut off because of that. I'm worried that's going to be me." And then move into, okay, what are you doing now to manage this? Well, like you're seeing the primary care. I see you have another appointment coming up. Have you started taking the medication? Oh, okay, you have. They mention what they've been doing. Build on that strength. So you went from general to more specific. You found patient strength. You can build on it. Conversations are scaffolding, and especially with patients, you are building something with them because you're not just communicating about details. Of course, that's part of it, but what you are doing is building a conceptual model or assisting them in building a conceptual model of what is going on. You are also building that conceptual model as well because we're never dealing with just one thing. We're dealing with a lot of things. And for each patient, they map and tessellate differently. When you get that narrative, you get the opportunity to pull that together. Now, of course, when we are in an appointment with for 15 minutes or seeing a patient for 10 minutes, we can't always do that. But for a CHW who's seeing a patient like this, or when you are in a capacity that you can do this, doing it well matters. And there's one thing to add, though. This all must be documented in your notes. If you have that conversation, but you don't document it well, it's going to limit the efficacy of that intervention. So make sure there's a nice, good note in there that describe what's going on. Because say he goes to the ER because he has an exacerbation of congestive heart failure. Say he has experiences diabetic ketoacidosis. Say he experiences hypoglycemia. Then we're going to be looking at the patient's notes, and those details are very important because the patient can't always communicate those in the ER. They can't always communicate those. So very important stuff. Make sure it's documented. And the nonverbal communication, it's important for you too. So Mr. Jones says, "Oh, stays all like this, and he's all tied up." What if you mirror him and you're doing the same thing? Well, that's going to make him close up too. So making sure you have open communication with the patient, open body language is very important. Um, yeah, the conceptual model thing. It really is what we do. Everyone has to do it when we all do this all the time, but we don't put the words to it. If you think of it like this, like you educating them about diabetes or educating them about congestive heart failure, that's just one thing. But if you're building a conceptual model of how this patient's individual disease states work together, conspire to create his outcomes, and of course, explain it in much simpler language to the patient, uh, they don't just build knowledge, they get aha moments because those conceptual models make things clear and real. If something's just a condition, it seems very esoteric, very academic, very not their reality. But when they create a conceptual model, it is their reality because they understand it and it maps together with their experience. The information that you have maps together with their experience. What does that say to them? It is real. I am experiencing it. I can make actions. That's what it says. Next slide, please.
Mary also put a few comments in there. She said, that's helpful, helping them build a conceptual model. At the start, I always feel overwhelmed by knowing how much this person is facing.
Mm,
Yeah.
that's the hard part, managing your own emotions. Let me talk about that for a second because I have that issue as well. Um, You need to connect emotionally with the patient, of course, but you need to be careful with that connection. It can emotionally connecting with the patient is a way to understand things better. When we understand a patient better emotionally, we understand the patient better because that's a model that we're creating. It's a conceptual model. We are understanding their experience through their emotions because we are mirroring them and feeling them. It's a core part of being human. We have neurons in our brain called mirror neurons that literally function to do exactly this. And people who are clinical tend to be very good at this. But the hard part about that is that connection can lead to burnout too, because you also experience part of the patient's pain. So I like to try to balance those as much as possible to affirm and understand that those emotional states, but to try to see it through an objective and through a pathological lens allows me to understand and touch the emotions, yet distance myself from them. And what I've noticed over with my experience is that keeping some distance emotionally is important, but also maintaining control over your emotional connection with the patient. There's a balance for everyone and everyone's work, but it can be overwhelming. If you're feeling overwhelmed by it, you may want to look at your processes of sort of um, how you're interviewing the patient, how you're thinking about that information, and sort of the thought loops that you're going through. I know I've experienced burnout before because of exactly this, and I just needed to take a break. And when I got back to it, I had different processes for dealing with them. So I think this is something that everyone goes through iterations in their career because this is emotionally challenging work. So I think it's I hear that comment. I've experienced it myself. And I will say, watch your own emotions very closely and how you feel because um, uh, emotional burnout is the easiest way to burn out in medicine, in my experience. Next slide. Oh, this is the next slide. Mr. Jones's CHW utilizes the following techniques to facilitate his interview. Empathy, validation, and reassurance, telling the client that their emotions are reasonable and correct. Partnering and summarization, playing the coach, like role with the patient by reflecting on the patient's response to ensure that they feel understood and appreciated. Um, I love your realization moments, Mary. They're so vivid. They're building them all, telling us that they think what is think is priority one, priority two, etc. All of a sudden, um, okay, I need to hear you tell your thoughts there because I think you've got something to share, if you don't mind.
No, I don't mind. I just think we're going to hear some more construction noise. Um, you, s- so first you
It's
said,
fine, by the way. You're coming in very clear.
Yeah.
yeah,
So
right now
no
there's,
backhoes or anything, beep beep, nothing.
it's more like power drills and hammers, but um, you said, you said, and then kind of corrected yourself, we're building this model. No, actually, we're helping them build their model. And I realized when I actually hear more from somebody and I hear the whole pile, like on almost every level, what's difficult. And
Mhm.
then if I remember that they showed up today, so they know they're ready to, like they're clear on something needs to happen first, and then second, and then third. And by you correcting yourself and saying, wait, no, we're helping them build the model, I realized they're already doing all of this. I mean, this is what's been in their head for days and months. Like, how the heck do I do today? And I
100%.
don't think I realized until this second that I honestly thought that was part of my job
Well, I didn't
to
realize it until you mentioned it. So I think a lot of these things that we have our own conceptual models of what we do, and as we talk about it more, we become more aware of what
yeah.
our rules are and what we do. I have an analogy though that I think you'll like. I'm wondering, do you do any art on the side,
Oh
painting,
my God,
reading?
no. I mean, oh my God, meaning everybody says that, and I feel like that's just not something I can pull off, and it's a never mind. Talk
Well,
about
I'll give you an example then I think you'll understand, and the example is music or painting. Um, Think of it like this. When a patient has a story, it is like they are putting a picture in front of you or playing a song for you, and you're trying to draw your own interpretation of that. That's your medical note. Or you're trying to play that song
it.
based on what you hear. You only hear it once, but then you need to go play the song again. Um, and I say that because music, painting, this is just data, right? Colors, vibrations, words that patients are saying, it's just data. They are giving us correlations of data, and we are turning that into a finished work, which is the piece of art. That's the model. And I think art, music, and writing and narrative is really important to medicine because I think what a lot of what we do is very artistic in a creative sense because we are interpreting patients' narratives. What I'll encourage is, especially we were talking about emotional burnout, the more of that stuff in your life, the better. Music, reading, literature, it will make you feel better and it will make you better at understanding narrative in sort of a deep way. So, anyway,
Well,
I
let me just throw out this one thought and then I'll mute myself again. It's like if it's, I get that 100% I get that it would be useful. And then I realize if it's useful for me, it's useful for our patients. And if something's useful for our patients, it's going to be useful for us. Like maybe that's just no-brainer stuff, but all of a sudden it feels quite
mm,
much to me.
I hear you. And what I do is I keep a mandolin right next to me and I play music every so often. That's what makes me happy,
Now you're
even if
just
it's
showing
just
off.
5 or 10 minutes. What I tell my daughter is put a book right next to you and pick it up, something you really loved reading, and to invest in that part of your mind because it gives two things that are 'cause this is a medical this is a This is of course a medical a TTA session here, but it does two really core things. It makes you more resistant emotionally to burnout, and it makes you better at understanding complex narratives. Period. Like the science says that. So and I say that because we should. It's a promising practice. What I'll recommend. Um, but anyway, transitions and empowerment. Letting this is a big one. When you're coaching, I don't know if anyone has experience in athletics but there are good coaches and there are bad coaches. I've had a lot of coaching for athletics in high school and college, and my favorite coaches were the ones that really empowered me, that looked at something I was good at doing, and they helped me to build on those skills by saying, "You're really good at this. You should do this or add this to that," or "Good job." The ones I didn't like as much were the ones that were very discouraging, or that was a terrible performance out there. Or, you shouldn't have lost that. It's very similar when you're working with the patient because you are coaching them through life's changes, life challenges. Um, Empowering them is a huge part of that in building that confidence. Again, this guy had sciatica and he was going to work. You get a merit badge already for that in my book. Um, Build on that and tell him like these are incredibly difficult conditions. The pain gets really bad for this. How are you managing that? They'll tell you, and when they tell you, you say, that's really incredible. I've met a lot of people that can do that. That's it. I find the simplest compliments are the shortest too. If you wax poetic and tell them, that's incredible. I can't believe you did that. It does not seem genuine, does it? But something short and complimentary after listening, that's effective. Wow, that's incredible that you were doing that. I think that speaks really well to your ability to manage all of this too. That's it. It works. It works. Very simple. Make good eye contact too. I will say that when you're saying things. People need to understand that what you're saying is real and that you're not just, blowing wind at them. There may be a lot of wind involved, but if it is true, it will help build their self-esteem. Think of when you receive little compliments about things. Last session, Fide told me she liked the shirt that I wore before we got on. She's like, "I like that shirt." And you know what? I found out that I was wearing that shirt this weekend with something I went for her. I won't tell, but I was wearing that shirt. Remember on Saturday I was wearing the same shirt that you
Mm-hmm.
complimented?
Mm-hmm.
I
I
just
saw that.
realized that, but I think it's because you said it was a nice shirt. So when I was looking around, I was like, I look good in that shirt. I'll put that on. Now think about the patient. You say, well, wow, you were really resilient back then. That's incredible that you're going to work. I'm sorry you lost a job, but that's incredible that you're still doing that. And managing all this, that's great. Then maybe when he's at night, he's in pain and he's thinking, oh no, like I'm terrible, I'm doing awful. And then he'll be like, wait, no, I did okay. I did that for so long. Like I could do this now. I can A1C, I can get that back on 7.0 because you're giving him data. We thrive off of human feedback. You'll get it. You ever meet, you know what? And it's the same with negative stuff. If you say something negative, people will remember it for years, for years. If you say something positive to the patient that builds up their confidence and their ability to manage their care, you're giving them something that's going to last. It's going to last a long time because those compliments last. They'll remember that. I've seen people years later and they remember things like that. It's just little things like that really do matter. I can't emphasize it enough. And of course, we all feel overwhelmed by our jobs sometimes, and we don't see that. But I'm telling you that that's a real thing, and you will see if you haven't seen it already that it's a real thing, and it should make you feel better or make you feel good. It should make you feel good. Next slide, please.
Just a reminder about the time, Kevin, for the chronic disease portion.
Oh yeah, no, keep going, keep going, keep going. Yeah. We get another session. This was a long one. And we'll go through this. Just kind of go through services very quickly. We arranged for him education access and quality. He didn't need any healthcare access. We got him transportation, behavioral health from the VA. We signed him up for benefits. We gave him utility vouchers from a community-based organization, and the social worker contacted the utility providers. They called them and asked for extensions. That works, by the way. I can't emphasize enough how much that works. If you have a social worker call, they'll do it. They'll do it. Um, Next slide, please. The first time I saw that happen, I was like, "Oh, that's cool." And then like I started seeing that happen a lot, and I was like, I need to give the social workers my bills, like so they can like negotiate it. Like they're good at that.
Mhm.
But people take it seriously. Utility companies take it seriously. And that's good to know, but like FYI, that works. Social and community context. We're getting him into a locals veterans group because this guy sounds to me like he might be self-isolating. So I think he needs to start hanging out with people that he wants to hang out with. And he's expressed interest in this. So we did. We got him connected to the local veterans group. Maybe he can talk to some other Desert Storm guys. Maybe he can, I don't know, start bowling with them. Who knows? But it adds richness to his social life and regular bi-monthly tobacco cessation check-ins. We're asking about that tobacco every time. And we're not beating him over the head with it. We're setting goals for reduction and cessation. Um, and of course, primary care is dealing with that as well. So we are working as an interdisciplinary team on that issue. Economic stability, training and support services through the Facility Job Plus site, a veterans peer support group at a local church, and a temporary medication assistant so you can take the full dose. Next slide, please. Quick question. Oh yeah, okay. No, we can go back. This is all just data. We can go back. I want to spend some time on this question. We can close on that. And the rest is sort of stuff that folks can review on their own. It's epidemiological data. That's fine. But for PTSD, uh, folks are at times very resistant to come into the office. Providing them with telehealth gives them a way to get treated without triggering their PTSD. It scares them. They don't like being scared because they worry about having an anxiety attack. Give them the telehealth option. Next slide, please. We'll go through, this is some data from some research I did. Next slide, please. Showing that a very high proportion of people in public housing have issue with physical disability. Here, for example, 17.5 have an issue with physically feeding themselves. Next slide, please. As the activity of daily living from that perspective. HUD-supported residents, if you see HUD-supported residents who have disability, they often do not have disability accessible homes, and there are often resources to fix that. Ask the questions. A very large proportion do not have that. Next slide. It was from a GAO report. Next slide. And next, we'll go to the next case study. We have a few minutes. Next one. And next one. Actually, take one back. I'm sorry. I'm rushing. Okay. Some practice recommendations. This is about so individuals with a with disability and with behavioral health issues. Excuse me. This is patients with cognitive disabilities have a very high rate of sexual abuse, extremely high rate. You should be aware of this and screen for this in your practice. So here's some information about this that can sort of be reviewed, including a really nice paper to read about that. But in general, these patients have very high rates of sexual victimization, tend not to report it. We are all mandated reporters for that. So be wary of your patient, ask them questions, and make it a safe space so they can communicate these issues when they are real. Next slide, please. Here's some information on it. Basically, it's between 1.5 or 3 times the general population rate, depending on the specific subpopulation. That is significant, significant. 3 times as much chance of risk of rape if you're a woman with disability than the general population. That's significant. That is the most vulnerable of these groups as well, women with disability. Be aware of it, and ask patients if they're at risk of safety. It's in the questionnaire, the non-medical needs questionnaire, and probe where you can. Next slide, please. Some more data on that. I really wanted to drive this point across. Next slide, please. This is a very vulnerable population. So I will leave you with this, which is a case study that you can review on your own time. It is about Mr. Tarzia. He has congestive heart failure, hypertension, and he is going to be going through an exacerbation where his chronic diseases are going to get a lot worse, and they are going to affect his life, stability, and safety. I go through this in an organ system perspective. Next slide, please. From an organ system perspective. Next slide, please. Thanks, Fide.
Next, okay.
Yeah, if you don't mind. And after that, sort of show how things progress and how these conditions build on and help create each other. Next slide. And then kind of, can you go through the arrows? And then how, could you kind of scroll through it like, oh, this is the one, this is the one. And then how they conspire together. And I will say, every patient you ever have that has more than one chronic disease is experiencing a graph like, or a graphic like this, where their CHF and their pulmonary edema they're making each other worse and feeding off of each other. Their CHF and their major depression are working off of each other and they're making each other worse. That's affecting the chronic kidney disease, which is making everything worse. And it's not just random. They're following like physiological relationships between organ systems. And I find that fascinating and it helps me understand things. So when I look at a patient or I look at a situation, I can understand that and I can understand what's going on. And it emphasizes to me the need for holistic care. If you're going to try to solve something like this and you're just looking at the CHF or just looking at the MDD, you're not going to do it. It's 9/10, it's just not going to work because there's too many factors involved here. So that's what I'll say about that. And I will thank you for your service. Thank you for your participation and wish you the best in your career and your lives. Thank you.
Thanks, everyone. Thank you so much, Kevin. That was a wonderful presentation for all of the sessions. Thank you. So here are just a few more slides that you can also review on your own about the patient outcomes, just in more detail how all of these different aspects influence increased risk of experiencing violence. All these slides are going to be shared with you all. If you have any follow-up questions, you can always contact us directly at our email. Here is our contact information. You may contact me at fide@namgt.com or at kevin.lombardi@namgt.com. And then again, please complete our post-evaluation survey and let us know how we did as a whole. We will also be following up with you in about 90 days. So just a reminder, later on, if you see an email from us in 90 days, it's just us that we like to review where you're currently at, or how you have been able to implement all of the information that you learned throughout all of the sessions at your organization or your health center. So thank you, everybody. Here is our disclaimer. And it's been a pleasure to meet you all throughout all of our sessions. Thank you so much and have a wonderful rest of your week. And we'll keep in touch. Bye-bye.
CD, Kevin, thank you.
Yes.
So good.
Thank
Thank
you.
you. Thank you
So
so much,
grateful.
Mary.
Take care.
You're welcome. Thank you. Bye.